So my name is Brittany LeMonda, Dr. LeMonda. I am a neuropsychologist. So I know you guys have had a lot of, people talk to you in the surgery profession. So I'm not, I don't do surgery. I don't help out with surgery or anything like that. But I hope that this will still be of interest to you. So, today I actually am going to be giving 2 lectures. So today I'm sort of going to discuss the basics of neuropsychology. And then next week, I believe, or the following week, I'm going to be discussing some procedures that we assist in, actually surgery. So I shouldn't have said that I'm never involved in surgeries, but we sometimes assist with awake craniotomies and WADA testing, which is not a surgery, but a procedure. So next week I'll be talking about that. So I hope you guys will be around for both talks. I really would love for this to be interactive. I don't know exactly if you guys can post your questions during. Joshua, are you still there to answer that?
Yep. You could actually pull up the chat if you want while you're presenting. It should be at the top. It should be at the top.
Oh, I see. Is that the Q&A?
No, there's I think a more button that would say chat.
Oh, okay. Oh, I see. Okay.
Yeah, and so we don't see the chat on your screen. We just see your PowerPoint right now.
Okay. Great. Okay. So yeah. So please make this interactive. So at any point, if you have questions, just type them. I can see the chat now. Thank you, Joshua. So just let me know, and if there's things that you want to talk about further, we definitely can. Okay. So what is neuropsychology? So I think there's a lot of misconceptions about what a neuropsychologist actually does, what the field of neuropsychology actually is. So a neuropsychologist has a PhD or a PsyD. So they don't go to medical school, but they get a doctorate in philosophy with a specialization in psychology. And then a neuropsychologist actually does an internship and then a fellowship afterwards and specialize in neuropsychology. So it ends up being about 4 to 5 years of graduate school, a year of internship, and then 2 years of fellowship. So it ends up being around 8 years of training. And the field really looks at, sorry, there's already a question. Happy to answer that. So a PhD traditionally, the question is, what is your point of view on PsyD versus PhD? So it really depends what you hope to do with your degree. A PhD traditionally has more of an emphasis on research, and the dissertation project is usually a little bit more in depth. It's usually your own research idea rather than maybe a project that sort of is in existence, or sometimes people who get a PsyD sort of look at clinical data. So PhD idea is you're really contributing to the research, you're really developing your own question, and dissertations are hundreds of pages, and that's really a big part of your degree. And then I have a PhD, so I'm not totally familiar with exactly what a PsyD dissertation is, but that's sort of the main difference. The clinical training is about the same. You have to do a bunch of practicum throughout your training. And so, that's basically the gist of it. And then usually a PhD will pay for your graduate school, which is really nice. And a PsyD typically doesn't. So those are usually the differences. But the field of neuropsychology really looks at the study of brain behavior relationships. So we're really interested in functional neuroanatomy and how someone's behavior, their emotions, their actions. Oh, is it hard to hear? Sorry, I can turn off my AC. Is that better? Thanks for the update. Is that better? Can someone type in if that's better? Okay. Sorry, I had my air conditioning on. Okay, so we really look at functional neuroanatomy. We look at how somebody's behaviors, their actions, their emotions, their reactions can, oh, someone's still having a hard time hearing me. Yeah, okay. Maybe that's just an issue on their end. So, we measure those things in a systematic way, in a standardized way, in order to identify what parts of the brain we think might be malfunctioning, or if we think that there might be a lesion there. I'll sort of get into all the types of referrals that we have. There was one question about job demand, which I can get to sort of at the end. And then there's a couple questions coming in. I'm just going to keep talking, and then I'm happy to go back and answer, and I'll answer throughout. But definitely keep them coming, and we'll make sure that they address them. So we use standardized testing to sort of look at behaviors and emotions and actions and everything like that. So we'll get into that a little bit more. So neuropsychology is definitely in pop culture. It's in a couple of episodes. I'm sorry if you guys hear my daughter in the background, but she's bouncing around. But it's in a few episodes of Grey's Anatomy. They look at, I think, Adele Weber, for you guys Grey's Anatomy fans. They look at her. She is diagnosed with Alzheimer's disease in one season, and I think that they do some type of assessment with her. This Is Us. Mandy Moore's character, I can't remember her name, but she's diagnosed with Alzheimer's disease. They have her meet with a neurologist or a neuropsychologist at some point and give her the diagnosis and do some testing. I don't know if you guys have seen the movie Still Alice, but she obviously has early onset dementia. And then there actually some testing. I'm going to show you guys a clip. It was in an episode of Law and Order where they did some neuropsychological testing with an individual. And even President Trump. So if you guys have seen recently, Donald Trump has been talking, there's been a lot of talk about testing that he's undergone, and you know, he's been talking about his performance on the test. So, you know, not to get political, but you know, there's been a lot of that in the media these days. So let's see if this video works. So this is, sorry for this horrible, it's not such a great video, but it's sort of an interesting take, I mean, on what neuropsychologists do. Oh, you guys can't hear it? Uh-oh. Okay. I can hear it. Joshua, do we know how to fix that or no?
You could try stop screen sharing, and then when you start screen sharing, there should be a option at the bottom of the like screen share link that says like share with computer audio or something like that, I think.
Okay. Okay. So stop screen share. Screen share.
There's something like to check at the bottom once you've hit the screen share button.
Okay. Hold on. Oh, share computer sound, maybe?
Yeah.
Okay. Oh, to share your audio. Oh, uh-oh. It says to share your audio, please install the Zoom audio device. Restart your audio sharing application. Let's see how complicated this is. Okay, I guess we'll see if this works.
Do you ever have headaches?
You can hear it? Okay.
Yes. How often? Sometimes every day. Can you describe them? It's like my head's in a vice. Someone's stabbing me in the eye. I'm going to ask you to perform a few simple tasks. Memorize these 3 words. House, pencil, green. House, pencil, green, got it. Where were you born? Englewood, New Jersey. Who was the first president of the United States? George Washington. How many states are in the U.S.? 50. When were you born? May 27, 1976. What are the 3 words that I asked you to remember?
Okay. So obviously, things are always a little bit dramatic for TV, but and you guys can hear me now talking, right?
Yep.
Okay, good. Everything's always like sort of dramatized for TV, but some of the things that they were actually having him do are sort of legitimate. You know, we actually do have people remember lists of words, and then that big thing that he was like connecting the circles, that's actually is sort of a task that we give, but much smaller piece of paper, so they just probably blew it up. And then they had him with an EEG cap on. I'm not sure if you guys have had any of the epileptologists talk to you guys yet, but if you haven't, I'm sure you will. So sometimes we'll do that. Actually, we'll have a patient with an EEG cap on who has epilepsy during the testing. It's not really to look at their brain activity electrographically while they're doing the testing, but it's just to see if they're having any seizures during the testing that might interfere with performance. So that sort of explains a little bit of that. Yeah, okay. So I'm gonna just give a more of an in-depth overview of what a neuropsychologist does. Someone says it reminds me of the book Brain on Fire, and that's actually very correct. So the chairman of my department, the Department of Neurology, he actually is the physician. Dr. Suhail Najjar is the main physician in the book, and he is very much involved in autoimmune encephalitis. So I see a lot of those patients, but I think in the book they talk a little bit. Excuse me, sorry, just sneezed. Sorry, they talk a little bit about her functioning. All right, I'll sneeze at some point. So yes, that's a good thing to bring up. There's a quick question about the difference between neuropsychology and clinical psychology. So a neuropsychologist doesn't really there's sort of 2 branches of clinical practice in psychology. One of them is assessment and one of them is intervention. So neuropsychologists, I really don't do intervention. I don't do traditional therapy that you might think of, like somebody laying on a couch talking about their childhood. I don't really do that. I do cognitive assessments that I'll talk about more, where we look, as I mentioned, at those brain-behavior relationships. We know about functional neuroanatomy, that kind of stuff. So a clinical psychologist might have some experience with testing. Maybe they give IQ testing, but they don't have the same understanding of brain-behavior relationships that a neuropsychologist does. So neuropsychologist is sort of like a subspecialty within clinical psychology with an extra fellowship. So that's sort of the main difference. Is it possible to work in neuropsychology as a TA? I don't think so, because it's it's a PhD, and we don't really typically work with PAs unless obviously we're we do work with PAs in that when we're doing some of the procedures or the awake craniotomy, there's obviously PAs there. A lot of the neurologists work with PAs, but I don't really think that any PAs can really work in the field of neuropsychology. But that's a very good question, and maybe something to explore further. And there's another question about, can you specialize in evaluations for people with neurological disorders? You definitely can. I'm going to get into all of that. I actually typically work with patients who have epilepsy and dementia, but there's a lot, usually people who specialize in autism are more pediatric neuropsychologists, but yeah, you can specialize in one specific field. Your research can be in that area. Then there's people who just see, a ton of people. There's people like me, I see a lot of different types of patients, but I have specialized training in epilepsy. Hypnosis, is sort of a controversial, someone asked about hypnosis. One of my professors in graduate school actually did some hypnosis. I think it's controversial. I think that, you know, like a lot of things, there's probably a time and a place for it. I don't personally do it. So let me continue on a little bit. So we're going to talk about the neuropsych eval in more details, how it's helpful, different neurocognitive domains, the tests that we give. I'm going to talk about effort, which is sort of a fun thing to discuss. And I'm not sure that we're going to have time for any specific cases, but we'll sort of see. Okay. So neuropsychologists wear many different hats. So their question about can you specialize in autism or other neurological disorders, you certainly can. But these are, you know, just a handful of some of the neurological populations that a neuropsychologist might work with. So dementia is obviously a very big one. There's many different types of dementia. There's Alzheimer's disease, which is the most common. There's frontotemporal dementia. There's actually different types of frontotemporal dementia. So there's language variant where somebody has a really hard time speaking, their language starts to decline. Then there's the behavioral variant of frontotemporal dementia where the person becomes disinhibited, aggressive, sexually inappropriate. There's vascular dementia that can result from small strokes in the subcortical white matter and lacunar infarct. There is cortical basal degeneration, which typically impacts one side of the body first. There's Parkinson's related dementia. There's Lewy body dementia, which is similar presentation to Parkinson's, which is actually what Robin Williams had. Person has a hallucination. So there's many different types of dementia. And a lot of times a patient will see a neuropsychologist to identify which type of dementia the patient has, to identify recommendations and treatment plan and to follow them over time. All the different dementias have varying rates of how rapidly progressing they are and different things that are the main issue. If somebody has Alzheimer's disease, you know, there's a lot of concerns about safety. Are they going to wander off? Are they going to leave the stove on? Versus someone who, let's say, has vascular dementia, maybe has really poorly controlled blood pressure and diabetes, and you want to sort of maximize medical treatment, versus someone who has Lewy body dementia and is having hallucinations, and you want to try to give them medication or treatment for that. So really, you know, even though there's no cure for dementia, there's many different avenues for treatment. So it's important to know what the patient has. There are some neuropsychologists who specialize in learning disabilities and ADHD. You know, they'll do cognitive testing and they'll do academic testing to identify if there's a math disability or writing disability, et cetera. Epilepsy, which is one of my areas of focus. A lot of times if somebody has what we call refractory epilepsy, meaning seizures that are not well controlled, even with numerous medications, they might be a good candidate for epilepsy surgery. So neuropsychologists a lot of times will see patients prior to surgery to identify if there are patterns on the cognitive tests that can help point to a specific area of the brain that is not functioning well. And that might mean that that's where either the lesion is or that's where the seizures are coming from. Also, theoretically, if, let's say, so temporal lobe epilepsy is the most common. So if somebody has, let's say, left temporal lobe epilepsy and they're right-handed, so we assume that their left hemisphere is their dominant hemisphere, and we find that their language and their memory are really impaired, we know that if we take out that part of the brain, they might not really miss it because it's not functioning well to begin with and it's producing seizures. So we can help sort of think about outcomes and cost benefit. And then for my next lecture, we'll talk about the WADA procedure, which is another pre-surgical procedure, part of an epilepsy workup that can help lateralize functioning. That's really cool. I think you guys will enjoy that. Someone asked about CTE cases. So I do have TBI and concussion on there. We do sometimes see patients with multiple concussion and traumatic brain injury. CTE is another one of those sort of controversial topics and pretty polarizing in terms of what people believe. But yeah, we definitely see patients who have had traumatic brain injury or concussion. Is it hard for patients to cooperate with you when giving the test? Yeah, so I'm going to get to effort in a little bit, and we'll talk about that. It can sometimes be challenging if the patient has some kind of underlying mood disorder or anxiety. It can be hard when they're impaired and they start to realize that they're impaired during the testing, and that can be emotional for them. The testing can also be pretty long depending on the referral question. So yeah, sometimes it can be a little bit challenging for them to cooperate, but most patients know that, you know, there's a point to it, and they actually appreciate that, you know, we can spend a little bit more time with them than some other providers, just because, you know, that's the way that our assessments are designed. Someone's asking about treatment and testing for those with TBI severe concussion. So it really varies. So I don't really focus too much on treatment. I would send them to a different treatment facility. But if the person, you know, had a very severe concussion, it really or severe TBI, it depends exactly, you know, what type of injury it was, where they're at in the course of recovery. A lot of times, patients with severe traumatic brain injury end up having some kind of frontal contusion or frontal lobe syndrome, and a lot of times they're just executive or have behavioral issues, even if they don't have some kind of frontal lobe injury. A lot of times, just the way that the brain reacts to the severe trauma, there can be a lot of dysregulation issues. So a lot of it is also focusing on behavioral issues and mood issues. So yeah, that's some of what we look at. Do I think cognitive impairment is a better umbrella term for neurodegenerative diseases than dementia? So dementia, when I'm talking about dementia, I'm talking about specifically neurodegenerative diseases that sort of are non-reversible, or they can sometimes, there are some forms of dementia that can be reversible, actually, like normal pressure hydrocephalus. I'm not sure Dr. Langer or somebody else has spoken to you guys about that. Or somebody can have pseudodementia, which is actually severe depression in the elderly that looks like dementia to family members and loved ones. And then you do the actual assessment and you realize they don't have the same level of impairment or deficits that or the same pattern of deficits that you'd see in dementia, and they're actually very, very depressed. So cognitive impairment can refer to a patient with epilepsy who has issues. It can refer to somebody with severe TBI who has issues. So that's sort of an umbrella term for everything. And then dementia is one reason why you might have cognitive impairment. If that answers your question. Do I treat MS? I sometimes treat MS patients. Yes, we sometimes see them. We do have an MS specialist. So I'm not sure if he's going to be talking as well. So sometimes he'll refer patients to us. A lot of times, you know, patients with MS present with significant fatigue, slowed processing speed, retrieval issues, and it also depends on the type of MS that they have. If they have, you know, a type of MS that's sort of more progressive or relapsing, we'll sometimes see them over time. Okay, so to keep going, we'll also see some patients with tumors and brain lesions. We'll see them pre-surgically and post-surgically. So actually, yesterday there was an awake craniotomy that we filmed part of it. So when I talk to you guys next week, you'll see this tumor patient, what we did with him while he was awake during the surgery. But what we also did with him a full neuropsychological evaluation, because we want to be able to follow up over time and make sure that there's no language or memory changes. We also see movement disorders patients. Sometimes we see them before and after DBS. And we talked about TBI. A lot of times people with severe psychiatric illness, or not even severe, but, you know, chronic depression or bipolar disorder, schizophrenia, they present with a lot of psychiatric illnesses that can present with cognitive changes. People with schizophrenia, there's actually metabolic and sometimes structural changes actually in the frontal and temporal lobes. So a lot of times we'll see dysexecutive features or memory issues. And then a lot of times patients are referred to us for differential diagnosis. Does this patient have MCI, which is mild cognitive impairment, precursor to dementia, or do they have dementia? You know, sometimes patients actually have seizures that are non-epileptic. So sometimes we'll get referrals and the test data can actually help us figure out if somebody really has epilepsy or if they have non-epileptic seizures. Okay, there's a couple questions. I'll go to these before I go to the next slide. Someone's family member went to see a memory specialist at UCLA. Is that something you're training would specialize in? Possibly. I don't know exactly what their degree is. It could have been a behavioral neurologist, which would have an MD, or it could have been a neuropsychologist. So I'd have to sort of see what their degree was. Do you recommend all patients with previously diagnosed psychiatric disorders undergo neuropsychological testing to get a definitive diagnosis? That's a good question. I think that if a person has a psychiatric disorder and they feel as though it's impacting their cognitive functioning, their ability to function, go watch porn. Their ability to function at work or at school. Okay, I'm just gonna have to pause for 1 second. I'm gonna give you snacks. Yes, please. Okay, sorry about that. Forget what I was saying. What was the question? Oh, yeah, so if somebody has a psychiatric illness and they feel as though it's impacting their functioning, their concentration, their memory, etc., then they should definitely undergo testing to just make sure that, you know, that there's not some underlying issue or, you know, there can be different treatment options, etc. Okay, there's a lot of questions now. Okay. I'm gonna go on to the next slide, and then I can always come back because I want to make sure that we don't totally run out of time. Okay, so we talked about this. So the funny thing about our field, my field, is that we still give paper and pencil tests. So you can imagine how COVID has really made that hard when we couldn't really see patients in person for a little while. So you know, it kind of feels like sometimes we're not caught up with technology, but that's because, you know, our tests are normed, and, you know, they're sort of standardized based on, you know, huge populations of individuals. So, you know, the challenging thing is to get technology to have the same degree of standardized normative data that these old tests do. The other hard thing is to make sure that you have validity, construct validity. So, you know, if you want to measure processing speed, you have to make sure that the task itself is measuring processing speed or visual memory or verbal memory, etc. And it's a little bit hard to develop these tests and then get the appropriate normative data on them, so that it takes so much time. So people have a tendency to sort of stick with what they've been trained with, and those are really paper and pencil tests. The other thing is a computer can't always capture everything that that a human being can. So, you know, even though there's certain things that a computer can capture that a human can't, the flip side of that is that a human sort of has training in this and they can pick up on a lot more nuances than a computer. So we use paper and pencil tests for the most part that assess various functions, and they correlate with brain regions and networks. I mentioned all of our tests are normed. So if you just have someone perform let's say a processing speed task, you know, obviously someone who's 20 is going to perform much better than somebody who's 80. So we don't just look at the test, you know, sort of how did this person perform on this? We have to norm them. We have to look at how did this person in this age group perform relative to other individuals within the same age group. We also look at education. So as you can imagine, someone who maybe has, you know, 8 years of education is not going to perform quite as well on, let's say, a measure of verbal knowledge as somebody who has, you know, a higher doctorate degree. So that also matters because, you know, if you're testing them for dementia later in life, you would expect, you know, that, let's say, like a low average score is more of a decline for someone with a much higher level of education than someone with a lower level of education. There's a good question that just came in. How do you norm the test? Statistical analysis, baseline test. So that's a really good question. So the way that the tests are normed is there's means and standard deviations for every age group, education group, sex, other demographic factors. Depending on the test, there's different normative groups that you compare your person to. There's different types of samples. So you find the sample that best fits your patient, and then you look at the means for that group and the standard deviation, and then you can calculate a normative score. And they're all on different scales. There's scaled scores, there's Z-scores, there's T-scores. So they're all statistical types of scores. And there's different means and standard deviations depending on the scale. So then you can sort of look and you can see where the person falls on that particular test. You don't look at one test in isolation, which I'll get to, but you look at, you know, patterns and how they perform within a domain. And then there's also a question about baseline. So we also estimate a patient's baseline. We have some tests that we give that are resistant to change. Even in someone who has Alzheimer's disease, a stroke, severe TBI, there are certain tests that are called stay tests, and they're highly correlated with education. There's cohort effects, meaning, you know, age group, depending on when you're born, et cetera. And they sort of stay the same. Even if somebody experiences a significant brain insult, we expect them to stay the same. So that helps to estimate baseline. We also look at other demographic factors, such as where the person was born and raised, family level of education. We look at, you know, their age, their level of education, et cetera. So we can come up with some sort of baseline so that, you know, we're not just looking at then these normative scores in a dark tunnel. We're looking at them relative to where we think this patient once was. How do you work with neurologists in regards to the test? So usually a neurologist or, you know, I work closely with the neurologists and the neurosurgeons at Lenox Hill. That's where most of my referrals come from. So they will refer a patient to me, and then I'll see the patient, I'll write a report, I'll give feedback to the patient, and then the report will always go to the neurologist or the neurosurgeon. And then a lot of times there's communication back and forth, especially if it's a pre-surgical epilepsy case, we have epilepsy surgical conference. If it's, you know, a tumor patient, then we'll have conversations about that. If it's, you know, an NPH patient, we usually follow up with them. So there's a lot of communication about what to do with the patient. Okay, so you guys have probably by now, I'm assuming you all know the different lobes of the brain and sort of what they do. This one has like funny graphics. So, you know, the frontal lobe is, it's involved in higher order cognitive functioning. That's sort of, you know, what people like to think of. Things like planning, organizing, multitasking, shifting back and forth, initiating behaviors, disinhibiting other behaviors, judgment, etc. Okay. So let me see if this video will work. Oh no, it worked before when I opened it. Okay, so this video was on the marshmallow test. I don't know if you guys have ever heard of that or seen that. So it's a task given mainly to young children, and they're basically given, you know, a marshmallow or a treat in front of them, and they're told that they, you know, that they can't have it, and you sort of like watch to see them like lean towards it and like play with it, and then like, you know, some of them eat it. So it's sort of a measure of inhibition and seeing like at what point children sort of can disinhibit their behaviors. But, you know, there's a lot of different tests that look at frontal lobe functioning. and I'm sorry that this video doesn't work. When I opened this before, just before it worked. So sorry about that. Okay, and then the temporal lobe is primarily memory and language. And I guess this is not going to work either. So this was a famous patient who had, I think he had a bilateral hippocampectomy. So, you know, the hippocampus is where memory is predominantly, or one of the main parts of the brain involved in encoding and storing memories. And basically, this is a video of this patient, and his wife will tell him something and about, you know, like it's I think that they're talking about a family member's wedding or a family member's birthday, and within 5 to 10 seconds, he's asking her again, he's asking her again, he's asking her again. So he's essentially amnestic for learning new information. Parietal lobe, there are sensation and perception are there, proprioception. There's also integration systems within the parietal lobe of different sensory material. So, you know, if you're reaching into your bag and you're looking for your keys, but you find your iPhone instead, parietal lobe is going to help you identify that. And then this obviously is not going to work. Can't really remember what this video was, to be honest, at this point. And then, oops, sorry. And then the occipital lobe is our visual processing center. You know, it helps us with color differentiation, motor perception. You know, you're identifying me as a lecturer. Okay. And yeah, there's obviously that video is not going to work either. Okay, we'll just keep going. How are we doing on time? Okay. Okay, so the actual evaluation itself, what does that look like? Because I've sort of been talking sort of vaguely. So the clinical interview lasts anywhere, to be honest, between an hour and a half, which sounds probably very long. But we really try, and we have the luxury of trying to get, you know, as thorough as a history as we possibly can with the patient. So we obviously focus on cognitive functions. So we'll ask a lot about if the patient's having memory issues, if they're having language or word finding issues, if they're getting lost, if they're having problems with attention and concentration. We always try to ask the patient what they've noticed, and also family members to comment as well. Now, the reason for this is a lot of times in things like Alzheimer's disease, there's something called anosognosia, and that is this phenomenon where a patient really has no insight into their deficits. So they come in, they have no idea why they're seeing me. They don't remember seeing the neurologist. They don't think that they have any memory or cognitive issue whatsoever. And they're really, to be honest, very confused about why they're there. So if you were to ask them, you know, what's going on? Are you having memory issues? They'd of course say no. They'd say that they're functioning perfectly well. They would say that that there's no issues. Another thing that they often say is, you know, a lot of times patients with Alzheimer's disease stop really participating in normal activities that they once did. But you'll ask them, like, so, you know, what do you do in a typical day? And they'll tell you, oh, I go see my friends, and I read, and I go for walks, and I go to the gym. And the family members are shaking their heads in the background saying, you know, they haven't done this for 5 years. And then you'll ask them, okay, so what was the last book you read? And they'll, you know, just basically give some vague circumlocution about, you know, and no, Lala. No. Sorry, hold on 1 second. Lala, stop. Mommy's working, okay, baby? What do you want? I want. Yeah, you want one, okay? Got more food snacks? So it's very important to have collateral, to have the family member there, to make sure that that we get that information. Someone just asked, are there family members present? So the family members are present during the clinical interview, but we cannot have any family members present during the evaluation, because there's evidence that there's third-party observer effect. So if somebody knows that a family member is there watching them, it can impact their performance. So we don't allow family members to be there during the evaluation, but the interview is always very important. Do patients typically go through these evaluations once their condition has been developed extensively, or is there a way to catch it early to prevent it? So good question. It really depends what the referral question is. If we're thinking about a dementia referral, if let's say a patient has recently seen their primary care doc and they're just starting to have little slip ups, a family member might mention that, and then they might be referred to a neurologist very quickly, and then they might see us, very quickly. Maybe if, depending on the dynamics of the family, if they don't notice or if they're writing it off as normal aging, then it might take a little while for the patient to get to us. Sometimes patients don't get to us until, they're very impaired, and it's sort of sometimes hard to imagine that they haven't really been followed or seen a provider prior to that. But that's just for dementia. Then there's other things that other conditions where really varies when we see them. A big thing too is that we always focus on change. So let's say you have someone coming in for like I keep talking about dementia evals, but let's say you have someone coming in for a dementia eval and they have a history of ADHD, and the family saying, oh, they're so disorganized, they have trouble like paying attention, they procrastinate. That's not really a change, and dementia is really a degeneration of prior level of functioning. So you have to take that into account too. So somebody who has a history of ADHD, they probably were never going to be well organized, and they were probably never going to concentrate very well and have good sustained attention. So we always look at change. Some people come in, they'll say, yeah, my memory's bad, but you know what? It's always been bad. So that, is another thing we have to think about. And then we also discuss psychological functioning that can really impact cognitive abilities, obviously medical history, and then other health behaviors that can impact brain health, sleep, diet, exercise, et cetera. All these things impact brain functioning. And then the actual cognitive test, so the paper and pencil test that I was talking about, they take about 2 to 4 hours. Sometimes they're computerized, but as I mentioned, but usually they're paper and pencil. And each test that we give maps onto a different part of the brain or different system or network of the brain. So depending on how someone does on a specific test, we can say, okay, this area of the brain or this network is not functioning as well as this one. There's a couple of questions. To what extent does your assessment result play a role for patients to qualify for epilepsy surgery? So if the patient has, a lesion or a focal lesion, or, meaning they can see on MRI or on imaging part of the brain that's irregular, dysplasia, or an actual tumor, or, a cavernoma, something that a surgeon feels like is easily resectable, then they'll usually do that, sort of regardless of maybe what the other findings suggest. If it's much harder to identify a real seizure focus, and the patient is, let's say, incredibly high functioning, and we really feel like they'd take a big hit cognitively if they were to undergo a resection, then they might hold off, or they might try other options before that. Also the surgeon presents them with sort of the cost benefit for what the risks might be. Is there a way to tell if a patient's psychological functioning is impaired by stress? Yeah, so I don't know if you maybe mean if their cognitive functioning is impaired by stress. So we, in addition to the cognitive test, we give psychological screening tools. So not only are you observing the patient during the interview, and trust me, the observations are sometimes speak louder than words. You'll see a patient super stressed. They're putting themselves down throughout the evaluation. They're shaking their foot. They can't really sit still. They're very test anxious. So obviously, if that's the case and that's their presentation, we know that stress is probably playing a huge part in their functioning and might be impacting the test scores, of course. But we also give some subjective self-report measures that have their own normative data, so that, we take, obviously take the clinical interview and their report of their mood, the observations, and then also the screening tools that we give to assess mood, anxiety, personality, functioning, etc. Can you give specific examples of the types of tests you give per diagnosis? Yeah, I have a slide where I actually go into the tests, I think, in a couple of slides. So then, as we discussed, we score the test and we analyze the data. I think we already mentioned this, but the raw scores get converted to normative scores depending on, there's all different types of scales. Some tests are not normally, some tests are normally distributed, like IQ. We know that, average IQ is 100, and then it follows a nice bell curve. But other tests are not normally distributed. So for example, like, nobody's really an expert namer. It's sort of the type of thing like, you're either adequate at being able to retrieve names of objects presented to you, or you have a deficit in it, some level of deficit. So that's actually not normally distributed. And in that case, a lot of times we look at, the patient's raw scores rather than normative scores. Sometimes raw scores tell you more than normative scores. And then we analyze the test data, we integrate that into a report that has the clinical context, history, everything that we discussed in the interview, behavioral observations, neuroimaging, EEG results, and then of course the test data. And then the formulation is always integrative. We never, do it in isolation just with the test data or just with the clinical interview or just neuroimaging. And sometimes, neuroimaging is not consistent with the cognitive test data, and we say that, and that it is what it is. So that's sort of what we do after the evaluation. So this is a normal distribution. I don't know if you guys have had any statistics yet, but this is a normal bell curve. And, it's always important to remember that within one standard deviation of the mean, 68% of the population will fall within this mean. And then as you get out to either tail, it's fewer and fewer patients. So it's always important to just keep that in mind when you're interpreting data, when you're thinking about statistics, etc. Someone asked, dementia isn't curable, so what would you administer or suggest to a patient to improve their quality of life? So it really depends on the type of dementia. If there's behavioral disturbance, it's recommending behavioral therapy or medications that can help with those symptoms. If it's somebody who, let's say, has vascular dementia, really poorly controlled diabetes and high blood pressure, we would discuss with them the importance of managing those factors to prevent future small strokes and white matter changes in the brain, which would escalate the disease. If, a lot of times what we recommend is family care, connecting with various resources and organizations to offer support to family. It's obviously a huge burden and life change and terrifying for family members. So a lot of it is just making sure the family unit is okay. So those are some of what we do. Okay. So we talked about this. Somebody asked this question earlier. So we always estimate, it's a horrible, it sounds so scary, but we estimate premorbid functioning or baseline functioning. And that can range anywhere from very superior to impaired. So we sort of have this ballpark understanding of where the patient once was before the insult or injury or neurodegenerative process or TBI or stroke or dementia process or seizures or whatever. Kind of have an idea of where they once were. There's a verbal reading-based measure that we give. We look at the demographic factors, occupation, age, educational attainment, region. Believe it or not, if you grow up in the South versus the North, there's different IQ estimates, rural versus urban, history of dyslexia or other developmental disability that might impact, baseline. And then this estimate guides our interpretation. So I think I mentioned this before, but a 66-year-old lawyer with memory scores in the low average range would be much more concerning than, let's say, a 95-year-old woman with 9 years of education with the same and with, let's say, English as a second language with the same scores. You'd be much more concerned for that 66-year-old than that 95-year-old. Remember, all those scores are normed for their ages. So I'm not saying that they got the same scores. I'm saying their normative data were the same. But it's not quite that simple, because there's this article, I won't go into too much about it, but I always think it's very fascinating. Larry Binder, who's a neuropsychologist, and his colleagues in 2009 published that, essentially everybody has areas of abnormality on testing. If you give enough tests, you'll find abnormal performance. So you have to also go into your evaluation with some sort of working hypothesis. It doesn't mean that you ever interpret your data the way that you think that it should be. As I said, there are some times that a patient with epilepsy will come in and, the EEG will show right hemisphere dysfunction, and there'll be a lesion on the right side. And then my test data say that it's more, let's say, left hemisphere. And I have to say that I can't, I have to be honest, obviously, with what the test data show. But it's important to sort of go into it with some kind of idea of what you might see. So for example, let's say you got a referral for a Parkinson's disease patient. We know that basal ganglia and frontal lobe systems are involved in that. So we would have a hypothesis probably that more of their subcortical networks, retrieval, processing speed, attention, inhibition, et cetera, might be more impacted than some other cortical functions like memory or language early in the disease. So you kind of have that idea before you're even interpreting your data, what you expect to see in a way. And it's also important that you do that so that you don't inundate and give too many tests, because if you give, the more tests that you give, the more likely you are to find an impairment. So it's important that you adequately measure each domain, but you don't want to bombard with tests, and you don't want to give the same test. Someone said, interesting that you talked about the naming test. My dad could name a bunch of things, but couldn't name who was the president. Is it normal to see this gaps in test results? So being able to meet, a lot of times naming who the president of the U.S. is considered more of like an orientation type of mental status check. You ask date, day of the week, month, year, season, etc. And then usually president is sort of in that to just see if the person is sort of able to be up to date in a way with like major current events. So I don't know exactly, that if your father was able to actually name pictures that were presented to him, naming the president of the United States is a little bit of a different type of test, if that makes sense. It's more of an orientation test than truly a word retrieval test. If the patient was not able to repeat 3 words they were initially given, what could that be indicative of? So you mean, I'm assuming you mean after a delay. So we usually are, so, you guys have probably seen, well, obviously the little clip I showed you from Law and Order, and then you might have seen like a MOCA exam or other things that are shown in the media. So we never give only 3 words. We give much longer lists or other types of verbal memory tasks. But if a patient was given some kind of verbal memory task initially and then they couldn't remember it later, it could be indicative of a few different things. So I'll just sort of delve into this, even though it's a little bit off topic and I think we only have 5 minutes left. But so if the patient had, let's say that they had adequate learning, so over the course of multiple trials, they were able to learn, a number of words within normal limits. And then we found that over the delay, they just forgot, they rapidly forgot. And then even if you gave them, let's say, hints and cues and prompts, they still couldn't pull any of the words out. That is more of a rapid forgetting problem with encoding and storage problem that we typically see in Alzheimer's disease. Now, let's say the same person, able to learn, whatever, couldn't recall any words spontaneously, but then you gave them hints and cues. and they were actually able to, then give a little bit of better responses when you gave them hints. That is more indicative of vascular dementia, because in vascular dementia, patients typically have a hard time retrieving things. But once you sort of prompt them, they're a little bit better. So it could mean a couple different things. Let me try to answer a few more of these questions. Does behavioral therapy actually work for alleviating dementia or slowing the progression? How does that work? Behavioral therapy won't alleviate dementia, no. If somebody presents with Alzheimer's disease with behavioral disturbance, or one of the other dementias that, like frontotemporal dementia, where there's significant behavioral disturbance, then you might see an improvement in those symptoms, but it's not going to reverse what's going on in the brain, and it's not going to cure it. Okay. What is your work-life balance? Well, obviously you see, I have my daughter right now. COVID has presented a whole new slew of challenges in terms of childcare issues, and I had a childcare cancellation today. So, the work-life balance is, you could always be working more, you could always be doing more, but at some point you have to turn it off. Some of the work that a neuropsychologist does can be done from home. If you've seen a patient and you have to be analyzing the data and writing the report, obviously that can be done from home. But of course, if you have a patient, you have to be in the office. But it's pretty decent. You're never on call. But you always feel like you could be doing more. You're typically sort of behind and catching up on reports and things like that. But it's definitely not terrible. Does a neuropsychologist have the same authority on prescribing prescription medication as a psychiatrist, or are they focused on non-medical treatments? So psychologists in New York State cannot prescribe medication. In some states they can, but not in New York State. So a lot of times I'll recommend, for example, like acetylcholinesterase inhibitors for a patient, and then the neurologist will actually be the one to prescribe them. So we can sort of guide if we think medication might be helpful, and then the neurologist or psychiatrist would actually prescribe it. What are your thoughts on ECT to treat people with severe depression? So it definitely can, I've seen it be successful in some patients, and then some patients feel as though it's not. In refractory depression, it's not. There's definitely, could be a use for it, but it sort of depends on, the patient and their response, et cetera. As a practicing neuropsychologist, what do you think you've learned in your career or training is pretty important that most people should know but do not? That's a good question. I think that I don't do therapy. Most people think I, do therapy and that I, see patients with depression. And I mean, I do see patients with depression, but that I sort of do intervention when I really do assessment, and that I have a knowledge of brain behavior relationships and functional neuroanatomy that other psychologists don't. I don't know if that's really the type of question you want. What are your thoughts about CBT by Dr. David Burns? CBT, I actually have training in CBT. We, as a psychologist, you do have to have some therapy training. That my program was a CBT oriented program. So a lot of Aaron Beck's work. When I have feedback with patients and sometimes they're having a hard time adjusting to the results, I'll utilize some CBT strategies. So I think CBT is great. I always recommend when I'm referring my patients to therapy, I always recommend that they see a CBT therapist. You typically work with neurolinguists. Do you find that people who speak multiple languages recover quickly? So that's a good question. I don't, I've referred to speech therapists, and speech therapists have referred to me. I don't work with them that frequently. People who speak multiple languages, it's interesting because, if we're thinking about like a traumatic brain injury or concussion, do they recover more quickly? Sometimes, I mean, some people sometimes feel like they have more of a decline in one language or the other, but then other times, it can be really useful if they are having a language decline, they might, they have both languages, so they might be able to refer to one language versus the other in order to get their point across. Someone asked for book recommendations. Oliver Sacks, An Anthropologist on Mars, is really good. Brain on Fire is really good if you guys haven't read that. If you guys are interested in CBT, since now somebody brought that up, a lot of Aaron Beck's books are really good. Are we out of time? Sorry. Oh my gosh, there's 42 messages. Or maybe they're just saying thank you.
They're all saying thank you right now.
Okay. Yeah, so I think I have my email on the first slide. So you guys can jot it down. Hold on, I'll go all the way back. And please, feel free to email me. There it is, the end. And then I'm also going to be on, I think, Joshua, next Monday. Is that right?
Sometime next week.
Yeah, I think next Monday.
Yep, next Monday at 10.
Yeah, so you guys will see me again. Sorry if I didn't answer your question. You can certainly email me. I tried to get to as many as I could. I'm sorry we didn't get through the whole thing, but kind of nice to answer questions.
All right. Well, thank you so much for joining us today.
Thank you. All right. Bye, guys.
Have a great day, everybody.
Bye.